get vitamin D. You know, you should not put sunscreen on when you get up in the morning. Everybody needs a little bit of sun. We are seeing an increase in rickets in kids who have sunscreen put on them first thing in the morning before they go outdoors. Recommendation is that they have some sun exposure first thing in the morning when the light is less intense, and then you put the sunscreen on. If not, they're apt to run into a problem. So, you remember that there are two layers, the dermis and the epidermis. Epidermis has several layers in it. You know, I think it's important for you to know the layers. I think the most important for you to know is that the dermis portion of your skin provides strength. And once that dermis has been insulted, for example, in a patient who has a pressure ulcer, it never gets back to its full strength. It will never be as tough as it was before that wound. So those patients who get pressure ulcers on their coccyx and we get them healed, they are at higher risk for redeveloping that than the rest of the population who has never had one. Collagen is also a part of your skin. Those are the tough fibers of protein that are in there. You know, and though that collagen is important for helping your patient to heal the wound also. On page 1177, box 48-1 in your book, there are skin-related issues to older adults. You should know that. That's one of the things you need to study. 1177. 1177. I apologize. I am wearing, you'll see me stop every once in a while. I broke a tooth off my dentures this weekend. I'm wearing an old pair and it has a sharp spot right here. I keep biting myself in the teeth.
You didn't drop it?
Huh? No, I did not drop it. I was eating, would you believe, yogurt when it fell out.
Oh.
I'm not a happy girl. And the box is 48-1.
Got it, all right.
Okay? And this is just another picture of the layers of your skin. You can see that better. It's not important for you to know all those discrete layers that are in the epidermis and the dermis, but just to have an appreciation that there are multi-layers there. And as those collagen fibers break down, you'll see that the patient will have skin that is at risk for shearing force, which means that when we go to pull them up in bed, if we don't see that we pick them up, you're going to pull the layers of skin away from each other, and that's one of the things that causes damage. So, pressure ulcers. A pressure ulcer is also called a decubitus ulcer. It may be called the bed sore. You know, it is caused by a local injury to the skin and underlying tissue. A true pressure ulcer only occurs over a bony prominence. If your patient has a wound someplace else and it's not over a bony prominence, it is not a pressure ulcer. By definition, it has to be over a bony prominence. You know, we already talked, I think, in lab, at least my group did, about some of those spots that we need to be careful of. Heels, behind the ears for oxygen tubing, you know, between the knees where patients' legs go together, keeping them off their coccyx, being careful of their hips, their ischium. Those bony prominences are the ones that break down the most often. And the thing that contributes to it most is pressure. That pressure is going to, over time, cause tissue ischemia. Ischemia means death. And then blanching of the skin. Okay? So one of the first things that you are looking at when you're looking at a red spot is you're looking to see if it blanches. Okay? If you touch it and the color comes back immediately, you've caught it in time. If you touch it and it blanches or it looks like a bruise afterward, you've got problems. You've got a developing pressure ulcer. The other contributing factor is the amount of time. That's why we said when we're positioning patients, some patients can't tolerate every 2-hour positioning. It has to be more often.
Could you explain the blanching again? I'm sorry.
Well, if you touch the wound and it blanches but the color comes back immediately, that's okay.
Oh, okay.
If you touch the wound and that color does not come back, there's something wrong, okay? And often what you see on the surface is the tip of the iceberg. It might be this big around on the surface, but underneath it's this big. Okay? Box 48-2, 1178. Characteristics of dark-skinned people with impaired skin integrity. So that's going to help you know. Yep, so if you look at that in your book,
Say it again, please.
box 48-2, page 1178, dark-skinned patients. It's going to help you identify impaired skin integrity. So your tissue's ability to withstand pressure has a lot of variables. Age is one of them, and that's why we see most of the pressure ulcers in patients who are aging. Mobility is the other. People who can move around in bed by themselves are less apt to develop a pressure ulcer or that type of wound. This is a pretty good look of one with a necrotic area. That necrotic area is this is necrotic. You know, this is just beginning to break down. Okay? And actually that necrotic area is pretty good looking compared to some. You know, typically that will be a very dark black, leathery, you know, it looks like dead tissue. You'll never mistake it.
Around the heel,
Yes?
the edge of the skin, was that debris?
Debrided, it could have been, yes. You know, what Abby's commenting is that this looks like it's down to some good granulation tissue that might heal, and they may have done that on purpose. They may have taken the patient either to
This part.
that part.
Yeah, was that?
Well, that might be a little bit of undermining that we'll talk about in lab. I'll show you on the model what the undermining looks like. You know, but this looks to me like maybe they have started to use, you know, an enzymatic debrider to get the stuff off so we can get down to tissue that will begin to heal. Okay? That's an unusual spot for one on the heel. They often are not on the side, they're often right on the very bottom and the back of the heel, because those patients wiggle themselves over so that their heels are on the bed and they are on their back. This patient must have preferred to lie on his side, because that's from pressure on his
How
side.
deep is that necrotic area?
How deep is that necrotic area? Very hard to tell. It probably goes right down to the bone.
Ouch.
You know, until you take that necrotic stuff off, you can't tell how deep it is. That piece of it is what we call unstageable. We can't tell how bad it is. So we have a case study. Mr. Omar Ahmed, a 76-year-old accountant, has come to the hospital again, this time for pneumonia. Before admission, he was unable to eat and lost more than 20 pounds over the last 2 months. 3 years ago, he had a coronary artery bypass surgery. As a precaution, he's placed on telemetry monitoring. He also has hypertension, type 2 diabetes. His mobility is limited because he is weak. So, what are your concerns for him?
Breakdown.
Absolutely. He's an accident waiting to happen. The fact that we know he's got circulatory issues.
Yeah, I can say something about diabetes, because I had 2 family members who had diabetes
Yep.
and lost a leg.
Yep. Yep. And that was probably related not so much to pressure maybe as to just circulation. But yes, the combination of, he's already got coronary artery disease, which means he's got some sort of circulatory issues. Then he's got type 2 diabetes, which has no doubt caused some damage to his microvascular system, so the smaller blood vessels, and the fact that his mobility is decreased because he's weak. He is a pressure ulcer looking for a place to happen. You know, he is almost a given for that. So, Mr. Ahmad is retired. He lives in a one-family home with his wife, Natalie. Their children and grandchildren live nearby and visit often. He complains that his bottom hurts from lying in bed. Okay. Lynn Abraham is the nursing student assigned to the medical unit. This is her first hospital-based clinical practice. Okay? So we've already stated what his risk factors are, and now I would increase that all with, he's telling us his bottom hurts. So he has some sensation there.
What is telemetry monitoring?
Telemetry monitoring is radio EKGs. In other words, the patient wears leads and a little battery pack that sends their EKG along antennas in the ceiling to a central monitoring system someplace in the hospital. Glens Falls has a big unit, like 46 beds. We also have 6 more telemetry beds on 3 West. And there's one monitor tech that sits in front of monitors on T6 and watches all of the people who are on telemetry. So they can keep track of what the patient's rhythms are. And the system is very smart. It picks up and alerts them, because it would be pretty hard to watch every single one of those people. But that's what telemetry is. So, risk factors for our friend. We already said. He has impaired sensory perception, probably because of his diabetes. You know, given that it sounds like he's fairly far along in the process. He has impaired mobility because he's weak. He could have alterations in his level of consciousness. He does not sound like that, so I don't think that would be bad. But if you do, if you have an elderly patient that's confused, they can't cooperate with moving off their pressure spots, or they are not going to stay positioned where you put them. All patients have shear risk and friction risk if we do not move them appropriately. That's the whole point of those maxi slides. How's your head, Bill, by the way? He almost went into the next room through the wall.
Does the patient twice my size, I mean, is that, like, if a patient weighs 400 pounds, is that the same device we use?
Certainly would. It would help a lot. And as I say, we also, and Saratoga does too, we have a hover mat thing. And that you have to be careful, or you can dump the patient off on the floor. That works so well. It's like an air mattress that has a pump that hooks to it, electrical pump. It blows up and it literally puts the patient on a pillow of air, and you can push him with a couple of fingers wherever you want him in the bed. Huh?
Table hockey team.
Oh, air
Oh,
hockey?
yes, it is. It's very much like air hockey. Same principle. Absolutely. So here's an example of what shear force looks like on coccyx. And you see, not just pulling the patient up in bed, but you see what it does when we have them sit in that particular position. So they are at risk when their head is at a 30-degree angle. Now that's the way lots of patients like to sit. What do you think you could do to minimize that?
Raise their knees.
Put their knees up a little bit. If they didn't have any contraindications to their circulation that we were concerned about, if you just put the knees up a little bit on those beds, that's going to keep them in that spot, and they aren't going to be doing that slide down thing that they do all of the time. You know, they're better off flat if they can breathe flat than they are sitting like that. So, classification of pressure ulcers. I don't expect you to get to be, an expert at this.